Venous thromboembolic events are a clear safety and quality concern that deserve our focused attention. What we need to know is how to identify patients who are at risk, when and how to treat them, and to track their outcomes. In 2008, the Plastic Surgery Foundation funded the VTE study, and this report by Pannuci and co-authors represents additional information gathered from the 4 collaborating sites participating in this study. The risk stratification and knowing who to treat is the first step in this process. In this particular manuscript, the authors compare the 2005 scoring algorithm with that from the more updated 2010 algorithm as it applies to plastic surgery patients. Table 1 in the manuscript highlights the differences between the 2005 algorithm and the 2010. Key factors are increased granularity in the weighting used for BMI and surgical duration, and also slight increased weighting on the presence of active cancer, as well as recognition that superficial thrombophlebitis history may contribute to the risk. The key findings from the study are that the 2005 scoring algorithm actually does a better discriminating job in the plastic surgery patient population than does the 2010 factor. This would thus suggest that all of us in our practices should be working to implement the Caprini 2005 risk stratification tool. This, however, is easier said than done. If we reference back to the November 2011 article from the VTE study published by the same group, we can see in their figure 1 that the process of ensuring compliance with use of the risk stratification tool is significant. In the initial steps of the study, there was 10% compliance. Through simple education, it increased to about 50%, and it was only through concerted efforts and full team engagement they were able to get the compliance rate up to over 90%. So what are the implications for all of us? We need to work hard, collaborate with our team members to systematically perform risk stratification, and then we need to be aware of evidence-based protocols for treating our patients. Ideally, we also have in position a mechanism to monitor compliance with assessing risk, employing the protocols, and then tracking outcomes. Of interest for those using electronic medical records and aware of the CMS criteria for meaningful use, the proposed rule for the second cycle of meaningful use includes several measures around VTE prophylaxis. All the more reason to get the team engaged and deploying systematic use of risk assessment on our patients. We are indebted to the Plastic Surgery Foundation for funding this study and to the VTE's 4 collaborative sites for putting this information together that will be tremendously useful to our patients going forward. But the onus is on all of us to actually implement this evidence at the bedside, one patient at a time.